So we're ready. So moving on. So the last part of this is this, and I was going to start it last time, and then I forgot that we had not done all the hard stuff. And that this is where this really starts. The circulatory pathways, it starts whatever this is, like the 44th slide. I don't love the illustrations, but we use them. And I like the regular illustrations as opposed to the pipe diagrams, which they love to use. And like this would not, this is a pipe diagram. That one's easy because there's not a lot of structures, but I don't use it ordinarily. Because this to me just argues more about the heart, and so it's not necessarily one that I would use. But today it's basically name the blood vessels. It's not a terribly long unit, okay? And that's really what we're looking at today. And I always do a diagram with my poor artwork to sort of simulate what's going on in that first one. So again, I don't get a lot out of these kinds of diagrams. They're talking about ones that are going to the head and neck, arteries, and then you have capillary beds, and then they come back, et cetera, et cetera, et cetera. Pretty obvious. You know, you have ones that are head and neck, ones that are in the chest, ones that are in the abdomen, and ones that are in the extremities, more or less. So, and the red and the blue are fairly characteristic for this. And how you memorize them or how you go about studying them is up to you, because everybody learns differently. The most important thing to understand is most of the named blood vessels, the companion veins have the same name. There's only a couple of oddballs. You're going to see one right away. The carotid arteries, there's no carotid veins. They call them jugular veins. They're slightly different. They're not exactly paired. The same thing with the heart. You have coronary arteries, you have what are called cardiac veins, but yet they all return back to something called the coronary sinus. Go figure. But they didn't consult me about this, way above my pay grade. That's a pipe diagram. You just can't, to me, I can't understand it. So I will occasionally, if I utilize something like this, because it will not have any of the labels, it would be major vessels. So you'd be looking at the abdominal aorta or the iliacs or the femorals or the brachial, some big structure. Because inherently when you draw lines, if I take a Sharpie and draw lines on one of these papers, it's not exact. And that's why I do have to take or be somewhat forgiving with the answers. Because I know some of those answers, you might answer one that's close enough. It's kind of like horseshoes.
Should we add this one or
What?
should we add this?
Why not? So this is the first one, and this to me is the most interesting one because it has to start. So we start with arterial blood, and it all starts at the aorta. And so previously was the pipe diagram, and so it starts with the aorta. Well, the very first vessels are really part of the heart. Right after the aortic semilunar valve, you have the coronary arteries right and left. The heart selfish, feeds itself first. That's the way I recollect. Then you get the aortic arch. There are three major vessels that come off the aortic arch. That's what I tried to do over there with that not so great diagram. Because if you want to think of it that way, the heart's on the left, we have to use a common channel to get to the right. Okay, so the heart's here. The first vessel it gives off of the aortic arch is called the brachiocephalic trunk. Once it says trunk, you know it's going to divide into something else. It's like the pulmonary trunk. You have right and left pulmonary arteries. Brachiocephalic means brachio for arm, cephalic for head. So we know it's upper extremity and head, neck, upper extremity. So here's the aortic arch, the heart here. It kind of goes underneath the sternum, the brachiocephalic trunk, and it immediately divides into two major arteries. They are, now it's on the right common carotid. When you see the term common, it means it's going to divide again, typically into internal and external carotid. Then the next way that it divides, it sort of forks. If here's the brachiocephalic, the upper portion of the fork pointing up toward the head is the carotid, common carotid artery. and it's named for the side, right. I don't worry too much about rights and lefts. And this is the subclavian, named because it goes underneath your collarbone, the clavicle. So the brachiocephalic trunk gives off the right common carotid and right subclavian. Both the right and, as you see, the left subclavian with my forearm, the first vessel. So here's the brachiocephalic, here's the carotid. What's left is the subclavian. The subclavian gives off the right vertebral artery. Vertebral arteries are that unique circulation. If you had me for AP1 or you recall it in AP1, you had the transverse foramina in the cervical vertebrae. They formed a little chain of openings that are really the backup circulation to your brain. Your brain relies on the carotid arteries. There's only two of those, two internals going to the brain. The vertebrals are the backup. And those vertebral arteries you will see come up on either side, one from the right and one from the left, just done schematically as opposed to for real. And then we have a skeleton someplace, got arteries sticking out of it. Or not, you're not that one. But they go along in these little openings that create a canal or passage. So they come up, and what you're going to see, they come up along the anterior portion of the brainstem. So if you recall your anatomy, they come up along the medulla, and right about the juncture of the pons and the medulla, they come together and form the basilar artery. That means like base of the skull, you want to think of it that way. It's on the interior midline portion of the pons, and that goes up and it forms eventually the posterior portion of the circulation to your brain. It's called the vertebral basilar system. So it's like a back. I mean, it's the great thing about the body design. Rather than just have, for a vital structure, we don't just have two channels to feed it. We have four channels to feed it. That's why if somebody has a blocked carotid artery, which is not uncommon, by the way, it's not like, oh my God, they're going to have a giant stroke. There's other passageways that can be utilized and until something is done to clear that, what they call a carotid endarterectomy, which is removing like a clot or a blockage, partial blockage in the carotid. Well, you learn something new every day. So as we follow that up, so that's the right side. On the right side, the carotid bifurcates or splits. Common carotid, internal carotid, goes up and it meets this very, very important structure, which is the centerpiece. And I had this on the quiz. There's a structure where we see the pituitary gland, the optic chiasm, and this structure, which is called the circle of Willis, which is the main blood supply to the interior portion of your brain. All of that is right on top of the sella turcica in the sphenoid bone. It's a critical area. So we always worry about pituitary tumors because if they have something has to be done with them, you can compromise the circulation. In the old days, people, if you operated on them, they typically lost their sight because of the proximity to the optic chiasm. It's a very, very challenging area to work in. So the internal carotid, now the external carotid, and if you wanted to go back to the bones, remember, how did you divide the bones? You had cranial bones and facial bones. Well, the cranial portion of the supply was the internal carotid. The facial portion is all of these named arteries: maxillary, occipital, facial, lingual, superior thyroid. And you'll see some of the distribution when you see the subsequent illustrations. Good? See, I've done this before. This is not my first rodeo. Moving on. So this is what it kind of looks like. We're looking at the right side here. So here's the brachiocephalic. Here's, now what's important about the bifurcation, this is where typically in CPR where you feel for a carotid pulse. And you use the angle of your jaw as, the anatomical landmark, and you feel in there for a pulse, like if you're going to start CPR. So it happens more or less right about in that area, in that location where we see the bifurcation. You can see it going internal and going external. So there's a lot of branches that come off of this, the external or the facial portion. The largest and the last branch of this is here, right over your temple, right above your ear and on the outside of your, sort of on the outside of your forehead or pointing towards you, is called the superficial because it's on the surface, temporal artery. That's the termination, effectively, of the external carotid. So, and yes, this would be an illustration that's on there. No, we're not going to do occipital arteries and maxillary arteries, et cetera, et cetera. But I mean, I'm sure I'm going to use that. You can see the vertebral arteries in that passageway, and the, as you can see, and along the cervical vertebrae that are there, all of that stuff. Okay, good. That's the subclavian. They have the clavicles cut away, but it goes underneath it. So that's that first nugget. That's looking from the right. The left is almost, they don't really have it here, and that's why I don't like. But it's basically the same thing, except the left common carotid's coming up there, and the left subclavian's going there. There's no brachiocephalic on that side. Moving on. This is a good close-up of the circle of Willis. And that's another illustration I use. Here's the pons. These are the vertebral arteries coming up and joining midline on the anterior pons, forming the basilar artery. And they kind of make up the posterior section of this circle. And the beauty of a circle is it's got feeders coming from, as you can see, the internal carotids. And so if there was a blockage here, blood could still get all the way around. If there's a blockage here, blood could come from either direction and get all the way around. So again, it's a nice, if you're from New Jersey, like I am, you know from traffic circles. It's the land of the traffic circle. Around here, they call them roundabouts. I don't know why, but they do. That's an Ohio thing. I'm talking about you. When you navigate, it goes, take the third exit of the roundabout. It's a traffic circle. I'm from New Jersey. So here you can see cell-tersic area, optic chiasm, da-da. Voila. And they do it color coordinated and all that good stuff. Close up. Again, another one of these interesting pipe diagrams that are very confusing to me. But it shows you the three vessels that I tried to draw. Subclavian, carotids, subclavians, vertebrals, etc. What happens when the subclavian artery when it goes under and starts to cross over the scapula, it magically changes its name. Same artery, it's the axillary artery. So it's like the Pennsylvania and Ohio Turnpike. Same road. When you cross the border, the name changed from Pennsylvania to Ohio Turnpike. That, as long as it's going over the armpit or axilla area, it's the axillary artery. As soon as it begins to grow along your arm or truly the humeral area, okay, it becomes the brachial artery. So it's one central artery that's located anterior in your arm, slightly more medial of midline. Why is that important? If you're going to do blood pressure, where you put the sensor. You don't put the sensor back here. The blood pressure cuff has a sensor to read the pulsations. You've got to put it over, and the brachial artery is a palpable artery. You can feel it. Okay? It's one of my pet peeves when I go and somebody puts the blood pressure cuff on wrong. I have a little hissy fit. Usually that's accompanied sharply by an elbow to my ribs from my wife. Stop that. And so what happens there, the brachial artery, and very often what you will see are what they call circumflex. You might remember that from the heart. It's kind of like an artery that goes around in the back, and very often they join back up again. That brachial artery bifurcates, divides, as you might guess, to a radial artery and to a ulnar artery. Makes common sense. Remember the anatomical position. So on the exterior, you have the radial or the lateral aspect. The interior, you have the ulnar arteries. Okay. What's interesting, and you see an analogous design in the lower extremity are here. These are called arches. Unlike a mechanical arch that you might see associated with the foot, okay, this is a passageway of blood vessels where there's a connector. So here, if I could look at my arm this way, here's radial, here's ulnar. They kind of divide, and there's a branch that goes up toward the back of your hand, okay, and a branch that's in the palm. Those two kind of come together, they arch together, and then digital branches, both on the palmar aspect and on the dorsum or the dorsal aspect, form arteries that go into the metacarpals and the digits. Another backup circulation. The beauty of that is if somebody got a bad accident, they cut, and an artery is bleeding, what we used to do was tie it off. I mean, you didn't necessarily have to sew them together because you had circulation. If it was on the top, the bottom circulation could take care of it. If it was on the bottom, the top circulation could take care of it. Okay? I remember asking that of a hand surgeon way back when I was a resident. Why don't we sew them together? He goes, we just need to tie it off and stop the bleeding. He said, there's enough circulation pathways so that the hand will survive or the fingers will survive. So it's very interesting. And you'll see the same situation on the foot where you have these arch or arcuating arteries that you will see. Love that. Whenever you see the term arcuate associated with artery, it's like arching in some way, shape, or form. So this is the actual illustration I prefer. So I use this, not the tube diagram. So here you can see as it goes underneath the clavicle, axillary artery, relatively small. Once it exits the area of the axilla and begins to parallel the humerus, roughly around the head of the humerus, and you can see it's somewhat more medial than central. That's the brachial artery. You can see the other branches, the circumflexing branches. Sometimes they're called the deep branches. You can see here, roughly in the anterior elbow area, another fun things happen in those natural cavities. Same thing you're going to see on when we get to the lower extremity. So that's an important area there. And then you see the diversion into radial and ulnar arteries, and then you can see the arching areas, palmar and dorsal. The most confusing one is here. So let me backtrack just a little bit. I'm going to go back to the heart. You can't really see it. It's right about here. You have the aortic arch. Then, and despite my terrible artwork, your aorta goes behind the heart. After the arch, it's called the descending or thoracic aorta. Okay. Next stop, because what the heart sits on inferiorly is the diaphragm. Three structures pierce the diaphragm: the aorta, blood going out, the inferior vena cava, blood coming back, and the esophagus for food passageway. Those are the three openings in the diaphragm. Once it passes the diaphragm, very famously, the name, again, it's all about location, changes. It is now called the abdominal aorta. That's a big vessel. So the next, there's not, in the thoracic area, you have some branches going off into the rib area, into the lung area. Not, they're called bronchial arteries. They're the ones that supply the lung. The pulmonary artery and pulmonary vein don't only produce maybe oxygen or waste product removal in and around the lining cells of the lung, but the rest of the lung itself is serviced by these bronchial arteries, which come off the thoracic intercostal arteries, which you might read about, which brings us into this important area. This is the toughest part of the circulation for students. Like I said, I've been doing this for 20 years, so yeah, hopefully you're different. This is the pipe diagram. So here it is, piercing the diaphragm. Take a look. What you're going to see is mostly, typically arteries. We're bilateral and symmetrical. You have two sides of a diaphragm, right or left. You have two adrenal glands. You have two kidneys. You have ovaries or testes, one on each side, right? Two legs. What's interesting here is you have paired arteries, but you only have one alimentary canal. You have only one gastrointestinal tract. And it's basically what it is a tube that runs through mouth to your anus. That's what it is. The blood supply to it, you have one stomach, you have one liver, you have one spleen. Effectively, the continuation of that tube is your small and large intestines. There's no right and left. So you have one blood vessel going to these structures, not right and left, but going anterior. That's the confusing part. The interesting part on the way back is that all of the blood from your stomach, small and large intestines filters back into one vessel. That's a vein leading to your liver because it's rich with nutrients, sometimes bacteria, viruses, sometimes toxins. All of that stuff has to be processed. So before it goes into the general circulation, it's got to make its way through the liver. You're going to learn about that shortly. It's called the hepatic liver portal, P-O-R-T-A-L system. A portal system is where you have a capillary bed and a capillary bed connected by a vein. In other words, an artery is not in the way. You may or may not have learned about that in endocrine. You looked at anterior and posterior pituitary. Right. I'm straining my shoulder, patting myself on the back. Despite the fact that Rodney still doesn't smile at me ever again. Nobody waved to me from when I was doing class today. Didn't you guys have class?
I didn't see you in there.
I'm hard to miss.
I wave every other.
Yeah, I know. And Kate liked me for one semester. Tough. Oh, yeah. So here we go. So let's look at the vessels, where they come from. So we're going to look at all these vessels. This is from the abdomen. It's a central vessel pointing forward. It's called the celiac trunk. Again, when you see the word trunk, it's going to split open into different. So it has a vessel going to the liver. That's the hepatic artery. Has a vessel going to the stomach. That's the gastric artery. And has a vessel going to the spleen. That's the splenic artery. So the question is, what three vessels come off the celiac trunk? Hepatic, gastric, splenic, liver, stomach, spleen. Okay? So you're going to see that. That's the celiac trunk. Down here, okay, there's some vessels that come off sideways, right and left, that we'll get to. The vessel that supplies most of the small intestine is here. It's called the superior mesenteric artery. The mesentery are the connective tissue, blood vessels, and nerves that sort of wrap around and supply nutrition and maintenance to the bowel. I mean, you've got 20 to 30 feet of that bowel. All right. So the superior mesenteric artery is the principal supply to that small intestine. And farther down, you're going to see the inferior mesenteric artery. That takes care of the rest of the small intestine and much of the large intestine. So we'll get there. So this is a good view, and I use this view. So I use this one, and I use this one. Here's the celiac trunk. Most of it's cut away. So what are the paired vessels? First, we see the inferior phrenic arteries. Phrenic, the PHR tells you where it goes. Diaphragm, PHR. Okay? So they're phrenic arteries. It's like we learned about the phrenic nerve, taking care of the diaphragm from the cervical plexus. So the first thing we see after the inferior phrenics is the celiac trunk and the three vessels. Then the suprarenal means above the kidney. What's above the kidney? The adrenal glands. Pair of those. Then in between the suprarenal and the renal, you have the superior mesenteric. The big thing to look at here is this, the width the size, the diameter of the renal arteries. They are disproportionately wide. The reason for that, everybody, is that the kidneys, which they supply, are by definition a high pressure filter. So you want the pressure of the blood being very close to systolic blood pressure. By the time it gets to be filtered in the kidney, the mean pressure, the average pressure, the typical average pressure in your bloodstream is about 93. Okay? It's only going to drop to about 55. Normally in a capillary bed, it's probably around 30. So it's the width of that blood vessel and its proximity to the heart makes that kidneys don't work if your blood pressure drops. That's what shock is. So it's really important. Constant low blood pressure runs the risk. Take it for somebody who is in intensive care with kidneys that had stopped working. I know, checkered health history, infections, kidneys. Look at me today. And there's one reason why I'm healthier. And her name is Patty Graves, and I've been married to her for soon to be 10 years. Or I wouldn't be here to teach you. I'd still be smoking and probably have taken the dirt nap, kicked the bucket, 6 feet under. See you later. So you can tell her I said so when you see her, if you see her. So there are the renal arteries. So now we get below the renal arteries. What's next? The gonadal arteries. And depending male or female, I mean, the ovaries are obviously in a different location than the testes, but they are, as you can see, dramatically, the size is much closer because they typically get smaller in diameter as you go farther away. They're much more proportional to the suprarenals. And then after the gonadal arteries, now you have the inferior mesenteric, the single artery, mostly to the large intestine. The end of the abdominal aorta is here. It bifurcates. There's a tiny branch that goes to the sacrum. Not a big deal for us. It terminates in the common iliac arteries. Again, if you see common, they're going to bifurcate into external and internal iliacs. Iliac, remember from bones, that's the upper bone of the hip assembly. You have the ilium, the ischium, and the sacrum. So the iliac arteries are think of them as being closed within the upper area of the pelvic location. Voila. So now you can see these are what mesenteric arteries look like. They supply this surrounding soft tissue that kind of keeps the bowel where the bowel is supposed to be. And we'll get into that after the break, after our spring break, when we basically do respiratory, digestive, urinary, and reproductive anatomy. So you can see the structure here, whether they're going from the superior mesenterics up here or the inferior mesenterics there. Now, everybody, we get into the lower extremity. Here's the pipe diagram. We'll look at one side. They're the same, right and left. So you have the first step. This is the aorta. We have the first bifurcation and it's not drawn where it's going. You have the external iliac, which is the larger. That's the one that's going to go into the lower extremity. And the internal iliacs. The internal iliacs are very significant. They are the major vessels that help supply additional reproductive structure. That internal iliac is the vessel that's involved in the arteries going to the uterine area that basically trigger menstruation, which we will get to when we do female repro anatomy and physiology. So they're really important. They supply, if you want to think of the internal iliacs, think of the area that's more pelvic oriented, deeper in the pelvis. Now, the upper part, more of the lower part where you have reproductive bladder, ureter, that type of stuff. That's part of there. So here we have, once the bifurcation, we have external iliac. The external iliac, okay, changes. And again, it's just a dividing line. It changes as it goes under the inguinal ligament. The inguinal ligament is a structure that goes from the symphysis pubis, and up here, the upper border, is the anterior superior iliac spine. That's a really vital structure. The iliac artery, the external iliac goes under that, becomes femoral artery. When you hear about someone having a sports hernia or a rupture, that's the area where it is. That's where the bowel, when that weakens, bowel can herniate through that area. It's really important. So my middle one, from job related from years and years ago, ended up, they had to do surgical mesh, which is not a great thing because he's had problems with it. That was a good 10 years ago or more. When he had to have that done because he was lifting stuff he was doing like automotive and that kind of stuff, some job he was doing. Nevertheless, so once it passes in the inguinal ligament, it's the femoral artery. The femoral artery is mostly, just like the brachial, it's in the front, anterior, somewhat more medial. Very interesting course. It gives off a deep artery that goes mostly posterior, and they come back together. They anastomose again. What's interesting about the lower extremity circulation is the femoral artery comes down this way, and rather than continuing anterior, it goes through an opening. There's an opening called the adductor, adductor hiatus, which is in the adductor magnus muscle, right along the supracondylar ridge of the femur. And that artery dives deep and goes behind, it goes from anterior to posterior. And when it does that, it's right behind your knee, and now it's known as the popliteal artery. And that popliteal artery, as it goes through this hiatus here, behind your knee, then it splits again. It's actually trifurcates. And it becomes the anterior, posterior, tibial arteries and the fibular artery. And those arteries continue down into your foot, your ankle and foot. And as you can see, the posterior gives off plantar arteries that supply, these are much larger and supply the bottom of the foot. And the anterior arteries on the dorsum of the foot. And then again, you have archways and little perforating arteries like we have in the hand that connect them. So it's very analogous. So this is the, I use this diagram. Here's the inguinal ligament. Here's common. Then you see the internal iliac goes internal this way. The external iliac. Now, as it gets underneath there, it splits. Deep femoral. Eventually, they come back together. The femoral. Here's the adductor hiatus. It goes posterior, and then we see the trifurcation. It's actually, I mean, it bifurcates and then gives off another vessel, but we call it the trifurcation. And as you can see, the anterior tibial goes along the top of your foot, and there's a palpable pulse that's hard to detect on top of your foot here if you press too hard, called the dorsalis pedis, which means top of the foot, and a very, very easy pulse to get behind the medial malleolus, called the posterior tibial. That, when it comes to pulses, the radial pulse and the posterior tibial pulse are the easiest, I think, to palpate. Here's the look from behind. That hiatus is up here. Popliteal is very interesting space. Like I said, a lot of action behind in these natural spaces. Popliteal artery, anterior tib, which goes from behind, goes through an opening in the tibiofibular syndesmosis. That's that soft tissue bond between the two leg bones. There's a little opening up top. It goes down anteriorly along the front of it. And you can see the end. So here's anterior tib, posterior tib, and the posterior tib goes off the fibular artery, which goes along the outer portion of the foot. And then you can see the arches that are there. Done with arteries. Aren't you happy? I used that previous diagram. Veins are basically, question? Which ones?
Yeah.
Oh, okay, from here?
From the beginning of
From the beginning of the arteries. See, I was gonna, but I can't. They still didn't give me my new contract yet, so this could be it for me. I'm not joking. I might have to retire and be in Florida. Would that be so bad? I talked to my best friend down there. Oh, Lou was 85. I was on the golf course this morning. I told him to perform an anatomically impossible act with a horse that brought him. Got to be this one, okay? This one, not that one. Not that. This one, not that. That one. Oh, God. You're, guys, stay up with me. I'll read them out. 1824B, as in boy. 1824C, as in cat. 1825B, as in boy. 1826B, as in boy. 1826C, as in cat. No, I don't use that one. 1827B, as in boy. 1827C. Good? I try to be. Veins. All right. If you want it with a broad brush, wherever the arteries are named, the veins have the same name, other than the one that we talked about with the coronary arteries and the cardiac veins and the carotid arteries and the jugular veins. A little note. This is important. I don't do a lot on the veins. I'll show you. The vein system is interesting because we have what are called superficial and deep veins. We didn't know that. So, I mean, everybody probably has had blood taken out of their body, right? More or less. Most have. If not, you're truly wild. The interesting thing about that is they can take blood out of your arm, and typically they use this here. It's called median. It's very easily accessible, not a problem to get. You have veins that come along here and here. They are, if you damage them, and believe me, over time you run into people who don't do a particularly good job taking out blood, or you have to have it done repetitively, you'll form little clots. You don't have to worry about it. Those are what are called superficial veins. If you want to look at it this way, if this is an extremity, for the most part, you have veins that take care of the skin. And you have veins that are deep that basically take care of the muscles and the deeper structures. The veins that we use for venipuncture nearly exclusively are superficial veins because if they're damaged, it doesn't damage significant circulation nor form blood clots that trap. They are connected by a series of veins called perforators. Okay? And basically what happens, it allows the blood from the veins near the skin over time in multiple areas to come back to the main circulation. Okay? And all of the veins, what's interesting about veins that arteries don't have is valves. Just like the valves in the heart, they have those cup-like structures, which you particularly see in the extremities, and you see those same kind of valves here. Okay? You see valves like that, but even in the perforated veins. They ensure one-way flow. So every time the blood, call it a column of blood. So if you walk and you use your muscles, the pumping action puts the blood a little bit closer back to your heart. It helps upset gravity. But when people are older, they don't have quite as much oomph in their circulation. So they play a pivotal role. Veins can be damaged. We see problems with veins. This is where varicose veins come from. People terribly with vein weaknesses, people overweight, frequently during pregnancy. All of those are things, and I would dare say 15-20% of all individuals suffer from some degree of varicose vein problem over time. So when we talk about these veins, I want to acquaint you with a couple of the main superficial veins because they're magnificent in a sense they're spare parts. They're not essential. You can get along without them. So in the days when they did a lot of open heart surgery, what they did was they cut out a long piece of one of those veins, turned it around, took out the valves, and used that to graft in place to bypass blockages in the coronary arteries. The acronym was CABG, which stands for coronary artery bypass grafting. They took your veins and put them effectively into your heart because they would obviously be compatible. And so they used to use the vein that's here called the greater saphenous vein, which runs all the way from roughly that inguinal ligament area down in front of your median malleolus the whole way. It's a lot of vein. You have veins that are on your arms. So if you do this, the names of those veins, and they come together in that median cubital vein here. You hold your arms out like this. The ones that are pointing up are called cephalic, and the ones that are down are basilic. So if you look at your arm this way, the one on the thumb side is the cephalic, the other one is the basilic. They cross over and meet in an area in front of your elbow where most blood is withdrawn. If you go to the lab for a typical venipuncture, because it's easy to do. And some of you will be doing that as well. Stick a few. Love that. So this is sort of where it comes from. So I do use this 1828B for your writing pleasure. Here it is. So I will show you the main flow comes up the named veins. So it comes up the tibial veins, the fibular vein, popliteal vein, femoral vein, and those femoral veins come together with and so you have, as they cross over into the abdomen, now you underneath that inguinal ligament, you have, those are external iliacs, they join with internal iliacs, they form the common iliac vein, and the confluence, that's what we talk about with veins, where they come together, form, very famously, the widest of all your blood vessels, the largest diameter, the inferior vena cava, cavernous vein. And that's the one that will pierce the diaphragm along with the aorta and go up and return blood from your abdomen and your extremities into your heart. Here you can see that saphenous vein. This is called greater, this is lesser or short. The short one kind of reunites with the deep vein behind your knee. The long one reunites with the femoral vein just before the inguinal ligament. In the upper extremity, you have cephalic and basilic. Here's the median cubital in the midline. They basically will come up and unite roughly around the subclavian area. Other than that, you have radial veins and ulnar veins, brachial veins, subclavian veins. By that time, the superficial veins, cephalic and basilic, have united, and they come together eventually and form, eventually would be the way to describe it, the superior vena cava. They actually have brachiocephalic veins when they join with the jugular veins coming from the head. And those two brachiocephalic veins come together and form a superior vena cava. So first look at the head, okay? And in the head, what happens is you have wide, flat veins. They're called sinuses. And these are sinuses along the sagittal groove, the superior sagittal suture, and in between that, when you begin to look at it, there's also a transverse sinus at the junction point between the cerebellum and the cerebrum. And as you can see, those come together eventually, and they feed in, and you get, well, eventually the internal jugular, and that joins with the external jugular, and that joins with the subclavian, and then you get these, and it's the same on both sides. Interesting. So it's a little bit different, the two brachiocephalic veins and superior vena cava. They kind of show it to you here a little bit. So again, you can see what's coming. That's the superficial temporal vein, some facial veins, maxillary, occipital, blah, 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 vertebral vein, all the same names, except for this becoming the jugular vein rather than the carotid vein. For whatever reason, that's the way they named it. And shows you the sciences. So I don't use the vein pictures. Maybe I'd use, the only one I would use from a vein picture perspective is probably that first one, 1828B. I just wanted to acquaint you with them in this discussion. This is the one from the upper extremity. Cephalic and basilic, median cubital, coming together around the axillary before the subclavian. And here you can see the radial and the ulnar. So you can see it here just as well. This is the interesting one. This is the one that's involved in the hepatic portal circulation. Here it is. The veins from the superior and inferior mesenteric collect the blood, effectively all the absorbed substances from the stomach, small and large intestines. They come together. It's a capillary bed leading into a vein, very famously the hepatic portal vein. That leads into all this hepatic portal system that feeds and filters its way through the liver to be processed, to be cleansed, to be basically have proteins and other substances manufactured. Eventually, the liver becomes, the outflow from the liver are called hepatic veins. The portal is between a capillary bed and a capillary bed here and feeds into the inferior vena cava. So when someone has cirrhosis from being excessive alcohol consumption, hepatitis, liver disease, they get what's called portal hypertension. There's so much pressure in that area, it backflows and creates immense problems. I mean, someone with that is in big trouble. They're not going to live very long unless they get a new liver, and even then. Okay. So, and now that's really the unique circulation. Remember, it's sort of the mate to all those arteries that point forward, going to the stomach and the spleen and the liver, the small and large intestines, the superior, inferior mesenteric. Everything else is pretty straightforward. Okay. Iliac veins, vena cava, renal veins, wide, gonadal veins, suprarenal veins, and you can see all these are the hepatic veins leading into it. There's that portal vein leading into the liver, coming from all those mesenteric veins. And then the lower extremity, again, fairly straightforward, coming up from the foot. Okay, you have dorsal veins, plantar veins, coming together from the saphenous, the superficial system, eventually into the popliteal, or up here into the femoral vein, and eventually leading into the external iliac veins, common iliac, and vena cava. And I just showed you a little bit better here. That's it. So next week, I will be up here about 45 minutes, an hour earlier with the door closed. Just putting out the label things when you come in. You just put your book bags and stuff on the wall, and I'll have the answer sheet, and I'll have the word bank. You'll have whatever your extra resource piece of paper to use, and I'll give you the instructions for that. Bye bye. Bye bonds.